Thanks for the warm introduction. Hi, everyone. I am Junko Tanuma, a doctor at AIDS Clinical Center in National Center for Global Health and Medicine. And so it's my extreme pleasure to be here with you. And I would like to thank all the people who organized conference and invited me and giving me a chance to talk about cancer in people living with HIV. So here's my disclosure. So in this talk, I will try to give you an overview of updates on cancers in people living with HIV. However, the cancer is such a diverse topic, so I constructed the presentation by considering the role of an infectious disease physician and a primary care doctor seeing people with HIV. And my talk is more on clinical presentation of AIDS cancer, risk and screening of non-AIDS cancers, and unique challenge of cancer treatment rather than the details chemotherapy of their outcomes. So first, I will quickly review the clinical presentation of AIDS-defining malignancies and epidemiology and risk factor of non-AIDS defining cancers in people with HIV. And second, molecular mechanisms of an increased risk of cancers in people with HIV. And third, summarizing the recommendation of non-AIDS cancer screening. And lastly, I will briefly touch on risk reduction and challenges in cancer treatment in people living with HIV. So first part is on clinical presentation of AIDS-defining malignancies and epidemiology and risk factors of non-AIDS cancers. So let me start with a classification of malignancies in people with HIV by its risk factor. You may be familiar with AIDS-defining cancers, which are mostly caused by oncoviruses, such as human papillomavirus, EB virus, and Kaposi sarcoma-associated herpes virus, KSHV. In addition to these viruses, hepatitis B and C viruses further cause non-AIDS defining cancers. And very importantly, multiple risk factors of cancers are very common in people with HIV, such as smoking, excessive alcohol drinking, overweight or obese, or for transgender women, gender-affirming therapy. So these risk factors cause various cancers shown in the slide with higher incidence than in the general populations. The lymphoma are the most frequent AIDS-defining malignancies. People with HIV are at 100 times higher risk of developing lymphoma than the general population. AIDS-related lymphoma developed from T and B lymphocytes, immune system cells at various stages of differentiation. Nearly 90% of lymphoma originated from B cells, and some distinct subtypes of lymphoma are more common than the other types. And the common subtypes of non-Hodgkin lymphoma includes diffuse large cell lymphoma, DLBCL, Burkitt lymphoma, and primary central nervous system lymphoma, and plasmablastic lymphoma, and primary effusion lymphoma. And the Hodgkin's lymphoma also frequently occurs in people with HIV. In such subtypes, two tops are DLBCL and Burkitt's lymphoma. And the DLBCL is the most common one, comprising about 45 to 50% of all AIDS-related lymphoma. The pathology of DLBCL is characterized as medium to large atypical lymphoid cells with large nucleus. The Burkitt lymphoma in the right is the second most common subtype and accounts for 10 to 35% of all AIDS-related lymphoma. And the starry sky pattern is a commonly used phrase in the textbook in describing Burkitt lymphoma that refers to a monotonous background of basophilic lymphoma cells as a sky in which clear macrophages are present as stars. Burkitt lymphoma can occur during stable ALT with a relatively high CD4 counts. According to our survey conducted in 5 hospitals in Japan in 2012, the percentages of Burkitt lymphoma among all systemic AIDS-related lymphoma increased from 7% in the pre-ALT era to 33% in the post-ALT era. In other important characteristic of AIDS-related lymphoma is that they are aggressively and rapidly progressing, and extranodal region, in particular central nervous system involvement and bone marrow involvement, are quite frequent. In the previous study in Japan I mentioned earlier, nearly 40% of DLBCL presented central nervous system involvement. A subtype of non-Hodgkin lymphoma that affects the central nervous system, including brain, spine, cerebrospinal fluid, and eyes, is known as primary central nervous system lymphoma, PCNSL. It is known as an important differential diagnosis of brain toxoplasmosis, although the incidence of PCNSL has decreased over time since the introduction of ART. HIV-associated PCNSL is typically EB virus positive, and detection of EB virus DNA in cerebrospinal fluid is a gold standard of the diagnosis. Unlike other brain cancers, PCNSL often responds well to chemotherapy and radiation therapy, but survival is quite poor compared to lymphomas outside the CNS system. Regarding KSHV-derived disease, most famous presentation is of course Kaposi sarcoma, but actually there are many forms of clinical presentations, including primary effusion lymphoma. And Kaposi sarcoma most frequently occur with the skin lesion, and the pathology is characterized by proliferation of a spindle cell of endothelial origin with abnormal vascularity. Extensive lesions, typically those on the lower extremities, in the picture on the left side, and are often associated with lymphedema. And such lymphedema may be due to lymphatic obstruction, damaged lymphatic drainage, leakage from dilated lymphatics, or regional lymph node involvement. A picture in the upper middle shows Kaposi sarcoma in the oral cavity, and the immune reconstitution syndrome after starting ALT can exacerbate Kaposi sarcoma. So in the case of oral cavity, we need to be careful because airway obstruction by enlarged tumor can occur after starting ALT. So Kaposi sarcoma can involve the lung. The CT scan image in the right shows diffuse infiltrations of pulmonary Kaposi sarcoma. So now let's move on to non-AIDS defining cancers. People with HIV have been reported to have higher incidence of various non-AIDS defining cancers, except oncovirus-derived cancers like anal cancer or liver cancer. People with HIV were reported to have more likely to have lung cancer and oropharyngeal cancers in multiple observational studies. On the other hand, frequencies of other types of cancers have different results. So since the cancers are caused by multiple factors, including age and lifestyle, these kinds of epidemiology studies should be continued to further understand the incidence of or evolving situation of non-AIDS defining cancer in people with HIV. So interestingly, according to the data in US, we are seeing declining trends of age-adjusted incidences of not only AIDS-defining malignancies, but also non-AIDS defining cancer over time. So this may imply that ART introductions and subsequent immune recovery by ART might be leading to reduce the risk of non-AIDS defining cancers as well. So on the contrary, the study also suggests immune deficiency might be causing the cancer in people with HIV. So when we look at causes of death in a population-based study in the US, although the cancer mortality has declined over time, but it remains high and represents a growing fraction of deaths in the HIV population, which means mortality from non-AIDS defining cancer may be rising as the HIV population ages. So this slide shows the trends include mortality rate for leading causes of death in the left, and the trends in age-specific incidence rate of all cancers in Japan by about 20 countries. So as you know, that Japan is a super aging country, and the cancers as causes of death and incidence of all cancers are continuously rising. So this data might give us some sense of the rising speed of cancer cases in our aging HIV-positive patients. So next, let me briefly talk about possible molecular mechanisms behind increased risk of cancer in people with HIV. So HIV proteins, like envelope protein GB120, accessory protein NAF, matrix protein P17 or TAT, and reverse transcriptase, all of these are known to be oncogenic per se, to induce oxidative stress and to be released from the infected or expressing cells. But HIV proteins can also act in collaboration with other non-oncoproteins originating from the oncoviruses, such as hepatitis B, hepatitis C, and HPV, as summarized in the slide. There are a couple of more mechanisms that might explain increased risk of cancers among people with HIV. A study using several molecular markers of cellular aging, including an investigation of changing levels of DNA methylation, shows higher biological aging acceleration was associated with mortality risk after a cancer diagnosis among people with HIV. As I mentioned earlier, immune suppression caused by HIV infection is one of the leading hypotheses of increased cancer risk of people with HIV. A large study from US showed patients who started ART with CD4 less than 350 or viral load over 500 and an improved CD4 count up to 350 or viral suppression of ART had significantly decreased the risk of both virally mediated and non-virally mediated non-AIDS defining cancers. In another large prospective cohort study in US showed people with CD4 count less than 200 at ART initiation had an 80% elevated risk for developing viral non-AIDS defining cancer. But still, there are a lot of uncertainties in the molecular mechanisms or the possible hypothesis that might explain the increased cancer risk in HIV. And we have to wait until more studies come out. So now let's move on to the screening of non-AIDS defining cancers. In terms of the HPV-mediated cancers, you may already know the benefits of cervical cancer screening as well as anal cancer screening. So regular monitoring of cervical pap smear in women living with HIV did show the benefit in prognosis by early detection and early intervention of cervical cancer. But there are some variation in the European and American guidelines in the age indications or utility of HPV genotype. So regarding the usefulness of a screening test, we should take into account many factors, such as cost, prevalence, or an impact of false positives. So whether HPV genotype may fit to all other places, we need more evidence. So regarding anal cancer screening, there is an important study conducted in US showing that regular active monitoring and the early detection of removal of HICL, high-grade squamous intraepithelial lesion, reduce the progression to anal cancers. Speaking about hepatocellular carcinoma, HCC, it is important to remember that DAA does reduce the risk of cancers, but DAA does not create a zero risk of HCC. So we should keep eyes on cancer risk and provide a regular screening of HCC, especially in the cases with cirrhosis. So this slide shows the guidelines of HCC screening across the world. They're different in detail, quite different, but in general, 6-monthly ultrasound is recommended. So now move on to other common non-age-defining cancers, such as colorectal cancer, breast cancer, lung cancer, or prostate cancers. So very importantly, these cancers are major health issue in the general population in many countries, and due to their high burden of disease, multiple countries promote screening programs of such cancers. And I think the principle of cancer screening in this category in people with HIV is that they must not be excluded from the such cancer screening programs, and we should do our effort to remove any barriers for their inclusion. So I think we have to be familiar with the local cancer screening programs and introduce them to our patients in daily practice. For reference, there are 5 cancer screening programs in Japan. And in my daily clinical practice, in the outpatient clinic, I'm always trying my best to encourage my patient to join the screening program and ask them if the results are okay. But we have to know the evidence behind the national screening program are not always robust. In terms of colorectal cancer screening, there are many test modalities currently under evaluation, but RCTs were only done with classical guaiac-based fecal occult blood and sigmoidoscopy, and its age indication in the colorectal cancer program differs by country. Regarding the breast cancer screening, the screening practice, even for general population, is always changing. And the best screening modality for transgender men and women have not been enough established yet, including for those inherited with the mutation in the genes called BRCA1 or BRCA2, who are at a very high risk of breast and ovarian cancers. So in terms of lung cancer, benefit of annual low-dose test CT scan, so-called LDCT, was confirmed in large RCT, but people with HIV were not included in the study. So we need to wait further evidence to establish the best lung cancer screening strategy in people with HIV. So what about prostate cancer? Yeah, it's more complex. Previous studies showed prostate cancer screening with biomarker PSA can reduce mortality, but the absolute risk reduction was very small. So there are still concerns whether the benefits of screening are outweighed by the potential harms, including the very substantial risk of overdiagnosis and treatment complications. So in the last part, I will briefly talk about lifestyle interventions and which we can do in the daily clinical practice and some challenges in treatment. So prevention is a key in every disease. So counseling about the harmful risk for cancers like cigarette smoking and excessive alcohol consumption is one of the things we can do at the primary care setting. And HPV vaccines are also crucial to prevent HPV-related cancers, and we should be familiar with the update of the guidelines. And the HPV vaccines are now recommended in the multiple guidelines, but there is some differences in the age indications. So in terms of the cancer treatment, people with HIV should receive the same standard full dose cancer therapy used in the general population unless there are data for specific cancer regimens in people with HIV. But there are special considerations in people with HIV receiving chemotherapy that we need to remember and share with an oncologist, including drug-drug interactions between chemotherapy and ART, and enhanced and overlapping toxic effects of chemotherapy and ART, and unpredictable decline in CD4 count, which frequently occurs during chemotherapy and radiotherapy, even or stable ARTs. And sometimes OI prophylaxis should be considered at CD4 count higher than 200 in person undergoing cancer treatment with chemotherapy or radiotherapy. So these special concerns may create hesitancy among oncologists in using a full-dose cancer therapy in people with HIV. A small study in US says HIV-positive cancer patients diagnosed with early-stage cancers, like a stage 1 or stage 2, were more likely to receive palliative care. However, they were less likely to have received any curative cancer treatment. This is very problematic. So, and immunotherapy right now has widely changed the management of multiple cancer or malignancies. However, efficacy and safety of immune checkpoint inhibitors are not well established in people with HIV. Only one international real-world study suggests that immunotherapy or immune checkpoint inhibitors for people with HIV seems to be as effective as in HIV-negative population with a very good safety profile. So why this evidence gap exists? And I think that one survey says the 75% of the early clinical trials of immune checkpoint inhibitor excluded people with HIV. And the earlier clinical trials, even it's a very high tendency of exclusion of people with HIV. So, and the many people are now demanding the inclusion of people with HIV in the cancer treatment and do not create any disproportion of cancer treatment. What? So I think, sorry. So, and also, I would like to, this is kind of last slide. So I think we need to more effort to improving access to cancer therapy in the worldwide. And the European group of oncologists in 2018 summarized the access to the cancer treatment across the globe. And as you can see in the slide, there are treatment access gaps in Asia Pacific. So we need to more effort on in decreasing these inequalities. So this is a summary slide. So an incidence of cancers of people with HIV is approaching to those in the general population, though the burden of cancers may be increased in people with HIV in the future as aging. And HIV proteins accelerated aging by HIV infection, immune suppression, and oncogenic viral infections may lead to higher risk of cancers in people with HIV. And there are strong evidences of benefits in anal and cervical cancer screening and HCC screening. And people with HIV must not be excluded from the national general population screening programs, though screening strategy of non-age-defining cancer vary worldwide and are being updated frequently. So people with HIV should receive the same standard full dose cancer therapy used in the general population unless there are data for specific cancer regimens in people with HIV. So more efforts are needed to improve inclusion of people with HIV into cancer clinical trials and access to cancer treatment in resource-limited settings. So that's all for my presentation. Thank you so much. And I would like to acknowledge all the people and staffs in AIDS Clinical Center. So if you have any chance to come to visit Japan, please let me know. Thank you very much.